My name is Chelsea Shallis, and I'm a dietetic intern at UTMB. My presentation is on a case study of a newly diagnosed GA-1 patient. I'm going to start talking about what glutaric acidemia type 1 is, the management of it. I'm going to assess my patient, show what the nutrition prescription is, her nutrition intervention diagnosis, the goals of this. Glutaric acidemia or aciduria type 1 is an autosomal recessive disorder, which means both copies in the gene have a mutation. And as you can see, the father and the mother are both carriers in this, and the child will have a 1 in 4 chance of getting this disorder. They'll have a 50% chance of being a carrier and also a 1 in 4 chance of being completely normal. So what happens with this? It's a defect in the enzyme gluteryl-CoA dehydrogenase, also abbreviated as GCDH. This affects lysine and tryptophan metabolism. So this enzyme actually helps break down proteins from food, more specifically the amino acids lysine and tryptophan. So whenever you eat a bunch of protein, whenever your protein breaks down, and here's a schematic just showing what's going on. The protein from food, as I said, and whenever your protein from your muscles and body tissues break down, they break down into your 20 amino acids. The other amino acids go off and get degraded and metabolized, whereas the lysine and tryptophan are unable to do this because the GCDH is not working correctly. Therefore, the glutaric acid builds up and causing significant health problems. This is a catabolic pathway involving the glutaric acid. So the initial newborn screen will show elevated gluteryl-carnitine, which is right there. And then after this, if this is shown on the newborn screen, they're going to do confirmation testing, which is a quantitative analysis showing elevated glutaric acid and 3-OH glutaric acid. So the clinical symptoms, well, the types and the severity varies for individuals. They're not always the same. You cannot rely on the signs and symptoms to identify the affected person because by then it's already too late. If a lot of the signs and symptoms are showing, there's probably already irreversible damage that has been done because these patients are generally born healthy. And one of the signs and symptoms that has shown up more is the macrocephaly, which is a larger head. But that also isn't very specific and can show up for other. If untreated, the symptoms can include acute encephalopathy, which is damage to the brain, or more specifically the basal ganglia. And the basal ganglia controls movement in the body. So whenever this is damaged, these patients can experience severe dystonic, dyskinetic movement disorders. They can have bleeding abnormalities, inadequate growth and development, abnormal motor skills, seizures, coma, and then this can even lead to death. These individuals are also vulnerable for metabolic crisis, and the vulnerable periods for this is 0 to 6 years old. So whenever your body is in a catabolic state, so how to manage this? Nutritional management and dietary treatment is one of the main ways to handle this. So a modified protein diet. You want a diet low in the lysine and tryptophan, but since all foods with protein contain these amino acids, patients have to limit their intake. So also for infants, breast milk, breastfed, or infant formula, they have to measure this in precise amounts. So for the sick day management and emergency treatment protocol, for this helps prevent the encephalopathic crisis by prompting treatment of illnesses. So you want to increase your energy intake. Here's a chart from a research article that shows generally what patients should have for outpatient sick day management and emergency treatment protocol. So as you can see, it increased the calories, carbohydrates, decreased natural protein, and increased L-carnitine. And both of these just show patients what they should be doing on the day. So nutritional status is typically assessed by looking at plasma amino acids. You want to maintain these in the normal range. You want to monitor for carnitine depletion with the plasma acylcarnitine profile. You want to have a complete blood count to monitor for anemia. Ferritin, monitor for iron deficiency. You want to monitor albumin. You want to monitor calcium, alkaline phosphatase, and phosphate for bone status. And then you want to do a routine surveillance for This is a glutaric acidemia monitoring chart I made over my rotation, and this just helps, as you can see under each marker, it shows the year of the patient and then how often they should be monitoring these lab values. And there is the second half of the chart at the bottom. So let's talk about my patient. My patient was a 7-week-old female. She was referred to the clinic at 2 weeks old with the abnormal newborn screen of an elevated C5DC of 1.17, whereas the normal range is 0 to 0.07. And then afterwards, there was detectable urine excretion of glutaric and 3-hydroxyglutaric acid. So for her birth history, the mother was on prenatal vitamins and she did get routine ultrasounds that were all normal. The baby was. For her social history, the patient lives at home with the mother and paternal aunt. The father does visit regularly, and there is no smokers or pets in the home. The family medical health history, there was a 3rd-generation pedigree done, but there were no pertinent positives. So prior to the visit, the patient has been on 3 different formulas, and at the beginning it did have added rice cereal for her reflux. So she started on Similac Advanced, she was changed to Similac Sensitive, and now currently on Similac Total Comfort. So the plan for this was to manage the diet with a lysine-free formula and start carnitine supplementation and create specific treatment protocols for this individual. For her physical assessment, she had a normal overall appearance. She was macrocephalic, so she had the bigger head. She had normal cardiovascular, abdomen, derm, extremities, and neurological assessments. For her anthro assessments, all parameters were plotted on the WHO curve, and this is a growth curve for children up to 2 years, and it reflects the standards of how children should grow at optimal conditions. So for her height, weight, and height for weight, these were all in the normal ranges, nothing to worry about. And then as you can see in the last row, her head circumference, that's what OFC stands for, you can see that was, and this is her growth chart for weight for age. So you can see she's trending normally. Height for age, weight for age, and then this is her head circumference. As you can see, she's above the 90th percentile, which means that she has a larger head than other normal babies. For her biochemistry assessment, her plasma amino acids were drawn before and after diet initiation. So at the first clinic visit, you can see her lysine was extremely high. It was 183 whenever it's supposed to be between 50 and 90. Her lysine to arginine range was a little bit low, and her tryptophan was high. So then then we started her on the diet, and then as you can see, her second clinic visit, her lysine is a little bit too low. So that means that we're going to have to decrease the formula amount a little bit more so we can get it in range, because we started her out a little bit higher, and then she was getting too much. So for the nutritional assessment, we chose the GA-1 formula, Glutarate Jr., because it has a higher arginine to lysine ratio. And the reason why we chose this, because decreasing lysine while supplementing arginine can give competition at the blood-brain barrier. So based on research, increasing the arginine to lysine ratio, in principle, can reduce brain lysine uptake by 50%. And this formula also had a higher carbohydrate and vitamin B5 content, and it does have a small inclusion of tryptophan. We also wanted to continue with the Similac Total Comfort because we didn't want to change her formula again after she's already been on 3, and she did seem to tolerate it just fine. So this provides 1150 milligrams of lysine per 100 grams. And here's where the lysine and arginine ratio can show. As you can see, the lysine and arginine use the same transport at the blood-brain barrier. So whenever you increase this arginine, it can help possibly reduce the uptake of lysine, therefore keeping the lysine down in the brain. So her nutrition prescription, we estimated that she needed about 100 or 110 kcal per kilogram per day. So for her initial nutrition prescription, when her lysine level was extremely high, we started her with 65 milligrams per kilogram of lysine. We mixed to a total of 20 ounces or 150 milliliters per kilogram. So as you can see in the Glutarate Junior, there's no lysine. They still has the protein and a high amount of kcals. And then our Similac Comfort had 265 milligrams, which equaled 65 milligrams per So for her revised prescription on the second visit, we didn't have new lysine levels, so there were no changes in this. However, we increased only glutarate based off her weight because she still needed more calories. And since we didn't know her lysine levels, we didn't want to give her any more of the Similac Total Comfort because we didn't know what range she was in, and we don't want to increase that anymore. So just to increase her calories, we gave her extra glutarate. Okay, and then her last prescription, her lysine levels were 42. So that's reflective of the 65 milligrams per kilogram. And as you know, as before, 42 is lower than the 50 to 90. So we wanted to increase her lysine a little bit. So we increased it to 75 milligrams per kilogram. And to increase the lysine, you have to increase the regular formula because the glutarate does not contain any lysine. So that's what we did for her, and we increased it accordingly to the 75 milligrams. So for the nutritional medical prescription, her feeding, we provided mom with mixing instructions for each change and each appointment that she had. Her current schedule right now is 3 ounces of formula per feed for 7 feeds per day for a total of 21 ounces of formula. She receives only glutarate if the 24-hour supply is finished. So she mixes all of her formula for the full day, so then she knows how much that she's had. It makes it a lot easier to just measure out and do it this way. And then she knows that if she has met her amount of lysine needed for that day, she can only receive the glutarate because it is lysine-free. For her sick day management, she is supposed to call the clinic if the baby is experiencing any illnesses with decreased appetite, vomiting, diarrhea, and or fever of greater than 100 degrees Fahrenheit. If the symptoms worsen or persist beyond 48 hours, they should not hesitate to go to the ER, and especially if the patient is not eating or drinking. So the initiation of a new formula prescription is also done, which is made in a 24-hour supply. It's the Similac Total Comfort of 12 grams, so as you can see we decreased that, and then increased the Glutarate Junior to 100 grams, and mixed to 20 ounces. She's supposed to offer the formula every 2 hours and make sure she drinks the supply within the 24 hours because you don't want the baby to go into a catabolic state if she's not getting enough. And then we're going to increase the carnitine to 2 milliliters 4 times a day. And the patient's supposed to take fever-reducing medications as indicated. And this is supposed to be followed for up to 48 hours. For her emergency protocol, the patient's instructed to take the emergency treatment letter to the hospital. So this is why it's made for each patient, because they need this to take to the hospital with them. The initiation of protocol at the hospital, they are supposed to start IV infusions containing 10% dextrose with standard electrolytes at 1.5 times maintenance volume, which this is double than what normal individuals would get. So if hyperglycemia becomes an issue, insulin should be considered instead of decreasing the GIR. In addition, the standard lab draws, the CMP, CBC, and CRP should be done, but they should also obtain the plasma amino acids, plasma acylcarnitine profile, and the urine organic acids to see if she's increased or not in those. They want to start the L-carnitine IV push. They want to treat any underlying illnesses or symptoms as indicated. And they want to stop the Similac formula intake for 24 hours completely. So if it's tolerated, you want to start the sick day recipe without any lysine in conjunction with the IV dextrose. Because since she's having this such of a breakdown in catabolic state, you can't give her any lysine or it could really cause a lot of damage to her. After 24 to 48 hours, once the patient is stable, natural protein can be reintroduced and increased stepwise until the amount of maintenance treatments is reached. And patients need to remember to consult with a genetics team to help facilitate this process, because sometimes in the hospital they just don't exactly know what to do. And it's really important to take this emergency protocol with you because it explains to the staff that this isn't just a common illness and that they must follow protocol to prevent this neurological damage in the patient. So her nutrition diagnosis was impaired nutrient utilization related to deficiency of GCDH gene as evidenced by abnormal lab values on the newborn screen and need for protein-restricted diet with medical formula. The second one was food and nutrition-related knowledge deficit related to new diagnosis of glutaric acidemia type 1 as evidenced by presentation to clinic for initial nutrition education. And this one was more tailored to the mom. For their nutrition intervention, we talked to the mom about the formula changes at each time and explained step by step how to properly mix this 24-hour supply. We provided her with WIC prescription, a gram scale, and 3 treatment protocols for her normal day, sick day, and emergency treatment management. And after we explained each step by step for the mixing, we also supplied her with a written out instructions just so she had it to make it easier for her. We also increased her formula and carnine accordingly to the patient's growth and lab values. This last time we increased 85 grams of glutarate plus 31 grams of Similac Total Comfort, and we'll continue to do this until we get her ranges in normal. We want to repeat the plasma amino acids to assess changes since increasing the lysine. So the labs will be reflective of the 75-85 milligrams per lysine intake at the next appointment, and then we'll make adjustments accordingly to her formula. The patient is to report how much formula she has remaining at home, and they continue to do this, so to make sure that she doesn't run out of this formula, you need to keep up with the pharmacy and the amount that you have. Because since these formulas are very more rare than normal, you can't just get it, so you need to make sure you really stay on top of it. For her goals of this nutrition intervention, we want to successfully follow the feeding recommendations to ensure the patient meets estimated daily needs for adequate growth and development. And the new mother has been doing a great job, and she has met this goal so far. We want to continue feeding approximately every 3 hours and keep track of how much the patient is consuming based on the 24-hour supply, which she has also been doing and met. We want to maintain the plasma lysine between 50 and 90, which we are progressing. We still haven't got there yet, but we need her lab values from this prescription. And her tryptophan greater than or equal to 30, which we have met. We want to maintain her plasma lysine ratio of 0.5 to 1, especially during her illness, but we have not met this yet. We want to maintain her total to free carnitine within normal limits, which we have not yet assessed. This will be assessed at the next appointment. And then an average weight gain of 25 to 35 grams per day, which she has met her 25 grams per day. And for this, we want to follow her WHO curve. Her frequency at every clinic visit, we want to monitor her plasma amino acids, and every 1 to 2 months, we're going to assess her total and free carnitine, and every 6 months, we're going to do her calcium phosphate, alkaline phosphatase, ALT, AST, CBC, and her serum ferritin and iron, and then yearly her albumin and prealbumin. So we're just going to follow the glutaric acidemia monitoring chart that I created during my rotation. And whenever I said following the WHO growth curve, we just want to keep maintaining her weight gain. So we need to follow by whenever she's growing, we need to increase her needs. So to sum this up, the management for this disorder is most crucial from ages 0 to 6 years old. For optimal growth and health, GA-1 must be controlled and treated before symptoms manifest, because that's whenever the damage is done and then you can't reverse it. The nutrition intervention requires continual monitoring and assessment. It's a lot of trial and error until you get the prescription just right. So as they're growing, you just need to keep monitoring it. And with appropriate treatment and action, patients will have normal outcomes. So it's really just reflective of how you're going to handle the situation and how the mother is going to be able to properly treat her daughter. So as a dietitian, you really must stay up to date with the latest recommendations and management. For instance, the lysine to arginine ratio recently has come out and started getting bigger. So there's always constantly new things and ways